Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome. I'm joined today by Hayley Berry to discuss the new update from NICE on the identification and management of the menopause. It's often said that the menopause affects 51% of the population, but I think we know that's not true. We all have either mothers, sisters, girlfriends and wives, and trust me, this affects us all, and we all need to be aware of it. From a healthcare professional point of view, in terms of making sure that prescribing of HRT is optimal, but also as human beings. So as I said, I'm delighted to be joined by Hayley Berry today. Hayley's an experienced pharmacist prescriber who's been qualified since 2003. She's got a background in community pharmacy and general practice and now works for the CPPE at the University of Manchester as the lead learning development pharmacist. But she also has a clinical role at a private menopause clinic, the NICE Clinic. She was a member of the guideline development group for NICE when NICE did their update to the menopause guideline, which is why we've got her on today, because we can pick our brains about the important update from NICE on this. That was updated and published in November 2024. Hayley's also got a keen interest in women's health, including contraception, sexual health and the menopause, and she sits on the faculty of Sexual Health Education and Training Committee as the pharmacist representative. Excitingly, she's also currently working towards her education doctorate at the University of Leeds and is focusing on menopause training and education for pharmacy professionals for that. So again, somebody I'm really interested in talking to about this menopause update. So Hayley, hello, welcome. Do you want to just start by telling us a little bit more about your career journey so far and what brought you to this point?
Thanks for having me on. I've used to work in community pharmacy, so I did my pre-reg in hospital when it was called pre-reg years ago, and quickly went into community pharmacy. I started off in a large multiple and then moved across to a supermarket pharmacy, which had huge benefits because it meant I could get really involved in service delivery and community pharmacy. So I used to really love having overlap time with the other pharmacists, and we would do lots of services like medication reviews, contraception, emergency contraception, when we could do vaccination. So I think that ignited my passion for sort of women's health and getting involved in offering pharmacy services. And then I decided that I wanted to go more into sort of education and training, so I moved across to CPPE full time. So I was a regional manager down in the West Midlands, so I had an amazing team down there, got involved in loads of different things. So that was where I got involved in the Faculty of Sexual Health. I also did my prescribing at that time as well, so we did some time in general practice, so managed to do a lot of work with some practices in West Midlands and really helped to understand the role of the pharmacy professional working in general practice. And then I also started working at the NICE Clinic, so I've been there I think for about 3.5 years now, working remotely initially, but then we've opened some clinics up north, so I get to do face-to-face, because I think that's one of the things that I really missed from my sort of community pharmacy practice role, was actually seeing real life patients face-to-face. So that is sort of a little potted history of how I am me, I guess.
Having that sort of varied career, that's been on a little bit of a meandering course, if you like, can be really, really helpful at allowing you or enabling you to acquire the wisdom that you need to be a good healthcare professional in the modern health service. I think also working as a teacher practitioner as well, you've got that theory of the education stuff with the pragmatism that you need to be either a community pharmacist or indeed a prescribing pharmacist, because you can't prescribe in theory. You have to prescribe to real people with real medicines and that have real consequences at the end of it as well. So I think having that mixture, I think, is really, really helpful. I am really interested in your work at the clinic. What sort of people would you see on an everyday basis, and what sort of things would they be asking you about?
So I guess I have the luxury of, because it's a private clinic, we obviously get a lot of time to talk to patients, which in my NHS job was never, we used to have 10-15 minute appointments, even as a pharmacist prescriber, to do sort of med reviews, which may or may not include menopause depending on time. So I suppose initial appointments are normally about 40-45 minutes. So you really get a chance to listen to the person in front of you and explore what it is that they're worried about. Quite often I find that women who come to the clinic, and probably whenever I speak to anyone about menopause, people are really well informed now, and it's actually quite and I suppose because I work in a menopause clinic, people have already sort of come with their own diagnosis because that's what they think they're dealing with, and it's just about exploring what their expectations are, what they're looking for. Quite often we talk a lot about lifestyle, about managing all of the symptoms, not necessarily just with HRT, but with other things that they can explore. So I see a variety of people. There isn't really various ages. So might see young women, might see women my age, might see older women who are accessing HRT to help with their symptoms. So it's a really mixed bag, I would say.
It's interesting. I'm sure people listening to this are going, crikey, 40 to 45 minute appointment times. Wouldn't that be lovely if we could have that in the NHS
amazing
as routine? I think there's a number of things there as well. So with it being a private clinic as well, there's obviously the health inequalities issue there as well. And I'm very keen to address health inequalities in women's health. I've done some work up in Scotland looking at potentially setting up services to run menopause clinics from community pharmacy for NHS Scotland. The people who you get to see at the clinic are the people, for whatever reason, they haven't been able to access the care that they think they require through the NHS, whether it's to see their GP, and for whatever reason they don't think HRT or their menopause symptoms are real and valid, and therefore they seek help elsewhere, which is why people tend to go to some of the private clinics. So I think you're right. I think you probably do see a particular snapshot of the population who are maybe well informed because they've probably been on this journey for quite a while, and they've read around and they've looked at various things on the internet and come with almost a preconceived idea of either what's the matter with them, but also what they're seeking to try and improve their situation there. So I guess it is very different to what the patients you would see in the NHS, but
Definitely.
but still really, really important. So just to talk about, and I think we've touched on this already, but just in terms of the challenges around the management of menopause in the UK and maybe even internationally, what do you think the main challenges are?
I mean, like you said, I work at a private clinic, so I have a skew view. I think there's a real lack of access to menopause care, both in the UK and internationally. There's also a real lack of research. So there is a massive lack of research in women's health in general, but specifically in menopause. And I know we'll pick this up later when we're talking about the guidance, but I think because of that lack of research, there's a lot of uncertainty. And I think that's both between healthcare professionals and with the people trying to access support. And I think that results in a lot of inconsistency of what support people can access across the country, because it's very varied. And that's what I experience with people that come to see me at the clinic, is they've come to a private clinic because they can't, like you say, they can't access what they feel that they need locally to them.
So the previous menopause guideline was updated. You were part of the guideline development group for that. Do you want to just talk to us about what your role was on that and how you found it, I guess?
So I tend to fall into things because people at CPPE are quite good at volunteering me for stuff, and highlighting things that I might be interested in, which is again a good thing to happen to me. So I was a pharmacist representative on the guideline update. So I was really interested. I went to some of the initial scoping meetings for the guideline. I can't even remember how long ago it was, Jonathan. Was it I feel like it was an eternity ago.
Well, I was still at NICE. It was probably about 3.5 years ago, because it's been one of those guidelines that's been quite drawn out in the development. There's been issues with the development of the guideline. So I think it was probably about 4 years ago.
Yeah, so that's when it started. I was just thinking, well, it's a good opportunity to get involved and something new that I hadn't really done before. So we used to have meetings quite frequently, 1 or 2 day meetings, either online or face to face throughout the course of the guideline development process. I don't think I realised how big the time commitment potentially would be. That's probably my mistake.
Yeah.
With all the preparation of reading when you're already busy with multiple jobs and other commitments. So I was basically the pharmacist rep on the current guideline.
The guideline development groups tend to have representation from various healthcare professionals, don't they? As well as lay members as well. So you'll have doctors, nurses, pharmacists, psychologists, as well as, I say, lay members as well. The guideline development group is usually about 15 to 20 people with a wide range of people and views, which is important actually for good decision making. If you're going to have good group decision making, you need people who have got different views. If everyone agrees with each other, you end up with groupthink. And that's not what you want on a guideline. You want to have a consensus, but that needs to be arrived at through careful questioning, not only of the evidence, but of the individuals involved in that as well. So just in terms of the headlines then, what's changed since last time?
So I would say, I mean, HRT is still the most effective treatment for symptoms, so that hasn't changed. And I think there was a lot of controversy when the guideline was first announced that was somehow different, but that hasn't changed. So
just to clarify, Hayley. So when the draft came out, the cognitive behavioural therapy was cited as an option alongside HRT for management of menopause symptoms, wasn't it? And the press release from NICE made it seem that CBT was somehow replacing HRT with menopause. That was never ever one of the recommendations, but the publicity and the press picked up on that, and there was a lot of controversy about that. But just to be clear, HRT has always been first line for menopause symptoms, and is in the update, isn't it?
Definitely, yeah. And I think it was a CBT that was sort of an additional option that they could have alongside, or for women who perhaps didn't want to take HRT or couldn't access, didn't want to have it for whatever reason. It was an option that actually NICE was then recommending. So it would be something that they could have as well as, or if they didn't want HRT, it could be in place of. But it was never said that was one or the other.
Yeah, and again, you'd expect that, wouldn't you? I mean, all conditions have got a degree of psychological components with them. It makes sense that for some people having a coping strategy using CBT could perhaps help them cope with their everyday life, but not always instead of the HRT. As you say, there might be reasons why people say, I don't want to take HRT because I'm worried about the risk of breast cancer or whatever, or have tried it and they can't tolerate it, in which case CBT would be a particular option there for that. So what else were the main changes in and if you like the challenges from the guideline?
So I suppose it's really important to remember that it was an update only. It wasn't a rewrite of the whole guidance. So there were certain areas that people really wanted comments and changes in, say for example testosterone, but actually that wasn't part of the scope for that specific update. So main things we focused on were genitourinary symptoms. So that section was all the evidence was reviewed and all rewritten. The effect of HRT on specific health outcomes. So things like breast, endometrial and ovarian cancer and cardiovascular disease, dementia and life expectancy. So that was all reviewed. So there's new recommendations there based on that. And also there was a focus on treatment options for women with symptoms who'd had breast cancer previously. So that was a new bit that was added in. So they were the main sort of sections that were reviewed based on evidence, but then they also did some changes where there wasn't an evidence review, but there was some wording reviews linked to fertility, when to refer to a healthcare professional with expertise in menopause and what that actually meant, what NICE said that meant, and linking to menopause and mental health, I think, was another area that was updated.
No, that's really helpful. There were the things that I took out of the guideline update as well. The other thing is, and I was always a big fan when I worked at NICE of putting in research recommendations. So
Yes.
recommendations where the evidence around this is we don't know because there's no good evidence that's been published on this. So it's really difficult for the committee to make a decision or a recommendation to say do this, don't do that, or think about doing
Mm,
this, think about doing that. For this one, there are 14 research
there are.
recommendations,
Yeah.
which to me is again amazing that there is such a lack of good quality evidence in this area. It makes you want to say to the research community, what are you doing around this?
Yeah.
Why are we still waiting to find out which is, for example, whether there's an impact of HRT on health outcomes in early menopause? What type of progesterone should be using for people with breast cancer who've got cardiovascular disease? These questions should be answered by now, but they don't seem to be. So let's hope the research community picks up on these and we see some good research published that can inform the next update of the NICE guideline. Eh?
Definitely, yeah, because and I think that's the thing. There's not a lot of good quality evidence to base decisions on, and I think
No,
that's, because I don't know, Jonathan, how many research recommendations it's normal to have with guidelines,
three or
but
four.
yeah, because I when I was there was a lot, and I think that is part of the difficulty with making recommendations is
Yeah,
there isn't a lot of evidence.
yeah,
There's not a lot of research.
and usually what you find in an evidence vacuum, you get polarization of views, which
Yes,
is exactly what you see in menopause, isn't it?
yeah,
You've got people at one side of it who go, you shouldn't be using HRT for anybody, sort of thing. We should be using other interventions there. And you've got the other side who are saying, but what's the issue with HRT? There's no safety concerns at all with HRT. The evidence is all being generated in using older estrogens that we don't use anymore, such as
yeah,
conjugated estrogens.
mm,
The newer forms of HRT aren't associated with the same degree of harms, and because we haven't got that really good high quality randomized control trial evidence in thousands of people, then you've got this argument that almost that ping pong between the two polarization of views, and of course what happens in the middle is you've got people like yourself trying to do your very best to run clinics for this, and women who are struggling to know what the right option is for them. And I think that brings us on nicely to the next point I wanted to make about shared decision making here.
yeah,
I think of all of the therapeutic areas, menopause is one which is very much a preference sensitive decision where the values and the individual considerations and concerns of the individual are paramount here. So
definitely.
one of the things that NICE have done is it's not a decision aid. You can't
No,
call
no.
it a decision aid because it doesn't fit the criteria for being a decision aid, but it is a discussion aid. It
Yes,
says on the front for GPs and patients, which is quite annoying because I
very
think this
annoying.
is for healthcare professionals and patients, not just GPs.
Yes,
But
I would agree.
yeah, but so what this does is it illustrates the risks and benefits of the different options in different classes of women. So depending on age, depending on whether you've got a history of breast cancer, all those sorts of things, and they publish icon arrays or Kate's plots where you've got 1,000 people who all take HRT, illustrates the risk of breast cancer in those people who take HRT compared to those who don't take HRT.
Yeah,
So again, from a shared decision making conversation, we talk about the second decision point, which is the options talk, where you talk about the benefits, risks, the alternatives, and what happens if you do nothing. The BRAN monomic is what we use here. So benefits, B for benefits, R for risks, A for alternatives, and N for no treatment. And this is the sort of tool that can really help facilitate those discussions between clinician and person. It's we were just discussing before. It's not well publicised on the NICE website, unfortunately. To find it, you have to go into the tools and resources tab, and you'll see it on there if you're looking
yes,
for it. We'll put a link to it in the show notes so you've got it directly. But yeah, this tool I think can be really, really helpful to illustrate that. So presumably during the guideline development discussion, there was lots of discussions about the need to provide this information to people to make an informed decision.
Yeah, definitely. And I think it's very much, again, it goes down to that individualized, that individualized approach for each person that's in front of you. And this is a really useful tool to help those discussions, to help those, because what is input, what I'm acceptable for my risk might not be
Yeah,
acceptable for someone else's risk. And then,
exactly.
and I think as well, it's because I've been at where I work for for like 3.5 years. It's not, no one is ever the same, and you never know what they're experiencing. It's all very much like, I always love listening to people at the beginning of their consultation, and because they're the expert of their symptoms,
Yeah.
and it's really good to sort of, you can use these sort of tools like this to go, actually help inform those discussions and those treatment options, and have a real, so it is properly shared decision making.
Quite right. I mean, there are no right and wrong answers here. There are
No.
only individual choices, and
Yeah.
for one person's high risk will be another person's low risk, and people will
Yeah.
make different decisions based on their own individual values and preferences. Our job as healthcare professionals is to facilitate that conversation and try and illustrate the risks and benefits with as much clarity as we can, based
Yeah.
on the evidence. And we've already said the evidence is already sort of, there are potential holes in the evidence here, but this is the best we have. So we've got that as a discussion aid. We've talked a lot on this podcast about the Julian Treadwell's site GP Evidence. We're massive fans of using that in consultation with patients as well. So again, I'll put the link in the show notes to this, but there is a menopause tab in GP Evidence. I know Julian is going to be updating this very soon. Now that the NICE guideline has been updated, he has put some text on there to say these haven't changed very much, but we will update them as soon as we get time to do that. So that's really helpful. And the other thing that I think is really helpful is the Winton Centre for the Public Understanding of Risk. This is David Spiegelhalter's centre that was based in Cambridge University. The funding for that came to an end last year, but one of the things that they're going to finish off is the update to the menopause decision aid. Previously, this was about 80 pages long. So it's taken them a long time to do that, but I know they're going to be publishing that in the near future. It should be updated. Now, because it's 80 pages long, it's not going to be for everybody, but there will be some people, and I'm sure some of the people you see in your clinic, Hayley, are really interested in the detail and in the minutiae of the different
Definitely.
options available. So again, it's all things to all people. It's about finding the thing that's right for the individual. Some people will just want the GP evidence, give me one or two illustrations here, and other people will want the 80-page from the Winton Centre. So again, it's about finding the tool that's best suited to you, I think. So yeah. So just to finish off then, what would you say the three things are for practice-based pharmacists around the guideline update?
I think I was thinking about this earlier actually, because I knew you were going to ask me this, obviously. So I from doing my research, I've only just started doing my research, interviews, and speaking to pharmacy professionals, so pharmacists and pharmacy technicians, about what their baseline knowledge is linked to menopause, because I think it's something that you can't be a master of everything, and actually it's something that you need to just equip yourself with, so you can effectively signpost people and show them, have some basic knowledge. I think the NICE guidance is 106 pages. Unless you're a sort of a specialist in that area and see a lot of menopause people that come to you with menopause symptoms, do I read when I was in general practice, do I read all the guidance that's not relevant to the area that I work, I see a lot of? Probably not. So I mean, I was thinking having a baseline knowledge of menopause in general. Is there someone in your practice or group of practices that is the specialist in that area, that you can ask about specific patients and get so that you can go perhaps and speak to them? I learned loads from shadowing. various healthcare professionals. So if menopause is something that you're interested in, is there someone in your practice? Is there an amazing doctor, nurse, another pharmacist, someone who is already seeing lots of menopause consultations, and is that something that you can shadow or speak to? And actually, I think I would probably say review the sections that have been updated. If you are familiar with the guidance anyway, I would just familiarise yourself with the changes. And look at the discussion aid so that you are able to effectively use it if you are asked about HRT and the benefits and risks. And I really like the way, Jonathan, that you said about best benefits before risks earlier, because I think that is still a massive thing, that whenever people speak to me, they're like, oh, the risks. Actually, there's lots of benefits. I think because I look back on my career in pharmacy and think once you've seen menopause symptoms, you can't unsee them. So I can be merrily talking to people outside of work and they'll be telling me all these things. And in the back of my brain, I'm thinking, oh, do you think that's menopause? Do you think that's, and I think that's, and I think as a pharmacy professional, you are in that enviable position of people come and talk to you, whatever sector you're in, and it's something that you can really help with identifying symptoms and helping them to identify symptoms. So even if you just have some signposting for people to be able to say to them, oh, have you thought, have a look at these resources, is this something that you might think about? And I suppose that's the final thing, is just thinking about where you can refer to. Is there someone in your practice, your group of practices, who is the menopause go-to person, or who is that in your area that you can signpost people to or book them in with? That sounds great?
Absolutely, that's really helpful. I mean, for me, as you say, what do you know already about this? What's your baseline knowledge on this? Here are some of the things that you need to make sure that you know, if nothing else. So I'm sure people know this, but CKS do a really, really good sort of overview, scenario-based update to management of menopause. They've just updated this their stuff in light of the NICE guideline update. So go there. As you say, this is a skill. Consultations are a skill. If you're having consultations with people around this, you need to practice it. So watch people who are already quite good at this and see what they do. Practice with the tools. Practice communicating to people, saying, right, if there were 1,000 people like you, and I know there's not 1,000 people like you because you're all individuals, but if there were, this is how many people would develop breast cancer taking HRT. This is how many people who would develop breast cancer who don't take HRT. Have those phrases at your fingertips to be able to have those conversations and practice it. And as you say, if you get stuck, have someone you can go to. It's like, phone a friend and who wants to be a millionaire. Have that friend who you trust. And that might be you, Hayley. I don't know. For some people,
it might be.
Who you just ring and say, I'm not sure about this. Can I just check this with you? That's something that's really helpful for people, I think.
Definitely. And I think I feel really lucky where I work now, because we're a big clinic, so you do have lots of other healthcare professionals accessible, so you're never sort of, and I feel really lucky, because I think back to when I was in general practice, and perhaps there was a few people that I would message and go pop into the room next door and talk to, but actually I communicate with doctors, nurses and pharmacists across the whole country, and and we're always supporting each other with peer support.
Yeah. I mean, I get the sense that there's a real sort of community practice developing around menopause now as well.
Definitely.
With yourself and others, and I think that's got to be a good thing for not only for the pharmacy profession, but for others as well. As we said right at the start, there appears to be some reluctance or fear about prescribing in menopause, and if there are things that we can do to try and allay those fears, then I think that has to be a positive thing for people who use these services. That's been a fascinating conversation, Hayley. Thank you so much for your time. Thank you all for listening. Please give us your feedback or suggestions for future topics or future guests, people you think would make a fantastic guest for me to talk to here. You'll find us, the email address to contact us is given in the show notes. It's talkingmeds@prescripp.info, and you'll also find us on all the usual social media outlets such as LinkedIn, X, and the lovely Blue Sky as well. So we'll see you soon in 2 weeks' time for a Christmas special with Jonathan and Lucy, and we're going to be talking about drug holidays. So we'll see you then. Bye.